I'm a surgeon. Okay. So my job is to put in the tube. I'm a surgeon with endoscopic interest. I do endoscopic procedures. So my role in this disease is only to put in the tube. As far as PEG tubes are concerned, the most common indication for putting in a PEG tube are neuromuscular disorders like motor neuron disease, strokes, and any other neurological disorder that causes difficulty or makes it impossible for the patient to swallow. So that is the most common indication for putting in a PEG tube. Nearly 90% of our PEG tubes are put in for that purpose. Yes.
Okay.
So what's your question?
Yes, there was a question from Rajiv. Can you ask?
Yes. Go ahead, please. Sorry, I'm not getting the audio.
Okay, Rajiv.
Are you getting the audio?
No. Give me, I think.
Yeah. Can you hear me, Surinder?
Yes. I can.
Now it's fine.
Now it's fine.
Okay. Okay. So, sir, like, mom MND is had gave also, and
I'm not sure I can hear you clearly, but there was a question sent to me. I think it is the same one probably.
Yes, the gave problem.
Yeah, so although I can't hear you, I will go by the possibility that it's the same question, that whether it can be done in a patient.
Yes.
It can be done in a patient. Now, GAVE or gastric antral vascular ectasia is a disease which is most commonly seen in patients with cirrhosis and portal hypertension, although it can be seen in other patients such as patients with systemic autoimmune disorders. Now, in any patient of portal hypertension, cirrhosis, portal hypertension, doing a PEG is a very, very risky undertaking. And although it has been done, but it's associated with a high mortality rate from the procedure, I would say almost 20-25% of dying from the procedure itself. So I don't know whether your father is a portal hypertension gave or some other associated disease. Does he have portal hypertension?
No, I'm not very sure about that. I know only that.
Does he have cirrhosis of the liver?
No, only they said it is only GI procedure, something they did in Gangaram.
Yes, but he must be having some underlying disease, which is GAVE is an endoscopic picture where the blood vessels in the antrum of the stomach are hugely dilated. It's called a watermelon stomach also because it looks like stripes on a watermelon. So there are hugely dilated blood vessels in the lower part of the stomach. Now, the lower part of the stomach is not a place where we normally put in the PEG tube. However, in portal hypertension due to cirrhosis with GAVE, there are other changes in the rest of the stomach also, which make it very likely that bleeding will be a very serious and sometimes fatal complication of a PEG tube.
Got the procedure of Ryle tube instead of PEG.
A Ryle's tube, of course, can be used because it won't have any consequences of bleeding unless the Ryle's tube ulcerates some area like the nasal cartilages. Then there may be a risk of bleeding if the patient is already suffering from a bleeding disorder, and cirrhosis of the liver is often associated with what we call coagulopathies, making it more likely for bleeding to occur.
Okay. So currently, Rajiv's mother is using Ryle tube.
Mother, is it? So in a lady, it may not be cirrhosis, it may be some autoimmune disease. Has she been diagnosed with some autoimmune disease?
It's ALS only.
Oh, it's ALS. Okay, so everybody here is ALS.
Yes,
Okay,
yes.
so I really don't have the exact information on that. I'm not sure whether even a PEG has been ever done. I certainly haven't done any PEGs on patients with GAVE. I'm not sure whether anybody anywhere has done a PEG on a patient with GAVE. I would say it is risky, and if it is possible to manage with a Ryle's tube, if there are no complications occurring, probably in her case it might be better to continue with the Ryle's tube.
Yes. Thank you, sir.
Okay, sir. Thank you. Thank you, sir.
You're welcome.
Gaurav, you wanted to ask something? Or Shilpi?
Sir, good afternoon.
Good afternoon.
Anjali.
Anjali, okay.
Sir, good afternoon. Anjali here, sir. Sir,
Yeah. Hi, Anjali. How are you?
He is, sir, very good. Husband, sir,
Yeah.
he is
How
also
is
very
he?
good.
He's doing
Sir,
well?
he is also going. Sir, can you see him?
Yes, I can see.
Sir, he is fine. He is smiling.
Yes,
Sir,
I can
only,
see him now. Yes, wonderful.
sir,
Can
only
you
one.
see me?
Yes,
Can you see
sir.
me? Yeah. Okay.
Yes, sir. Sir, this
How
is
are you, Mr.
the.
Pradhan?
So he is smiling.
Oh, good.
Sir,
Nice to
one
see you.
question. Yes, sir. So this is the tube, PEG tube.
Yeah.
Yeah. Sir, only some parts are become black.
Yeah, the tube actually deteriorates with time. Some of you have been using these tubes for probably years, so you know well that after the hot summer, the high temperatures, the tube sometimes becomes softer and collapses easily and may change color. Just a change of color is okay, because that may be due to many things. But if it is getting soft and pulpy, then it's going to get either blocked soon, or you will need to have it replaced. Normally, they advise replacement in 6 to 8 months' time, but very often you can probably carry on for a year or so without needing replacement. So if your tube is working fine,
So it
and
is
if it
fine.
is
Sir, it is
not going
fine.
soft,
Absolutely fine.
yeah, then go ahead and use it. No problem.
Okay, sir. Sir, one more question. Whether we should sachet, half of sachet every week to clean the tube?
The
So
best way to clean the tube is use warm water.
okay,
Preferably
sir.
before and after every feed, you must use warm water, maybe 40 or 50 ml of warm water to flush the tube.
Yes, right.
Make sure that everything gets out of the tube, and that's the best way to prevent blockage of the tube. There is no need to use any ENO or any other form of chemical process to try and prevent blockage. However, if it is actually blocked, then you could try first, of course, you try again flushing with warm water. You push a little harder, not so hard that you break the tube, but push hard with warm water again, 40 to 50 ml. If it doesn't go in, then suck and push, pull push type, and try to dislodge the blockage. If it still doesn't get unblocked, then you can try even some soda or some Coca-Cola, which has been actually some of the fizz has been taken out. You can try and push with that. That is if it is actually blocked. But if it is not yet blocked and you just want to prevent the blockage, warm water flushes after every feed is the best way.
Sir, my only concern is when after 1 year, maybe we need to supposed to change the tube. That time, it is for ALS patient at this condition, it is very difficult to go to hospital, and we'll face lots of challenges there. So is it possible to change at home first time endoscopy?
Yes, if you ask, is it possible? Yes, it is possible to do it. Now, there have been generally two or three ways to remove these tubes the first time. The second time and subsequently is no problem at all. It can be done at home. You can do it yourself, or any caregiver can do it themselves once they see the process. It is only the first time that is the issue, because the kind of tube we put in at the first instance has a little plug at the end, a bolster, which prevents it from coming out automatically or easily. Now, there have been cases when people have simply cut off the tube at the skin end, where it is coming out of the skin. You cut off the tube there and allow that little bolster to pass through the intestine, through the rectum, and be passed in stool. Most of the time, that is okay. But sometimes, and especially if the patient has some intestinal disease causing a little narrowing of the intestine, then this bolster may not pass, get blocked, and cause intestinal obstruction, for which the only answer is surgical removal. So the other second thing to do is, I'm talking of non-endoscopic procedures. This is one, just cut off the end of the tube and let the part which is in the stomach to pass in the normal passage. The second is to attach a weight to the outer part of the tube so that it hangs down, and slowly with the pressure, that bolster flattens out and comes out. This is even more useful in patients who are ambulatory, who are walking, sitting up, because the gravity also aids that process. And the third process, which is the most commonly used for the first time, is to put in an endoscope, cut off the tube from outside, catch the bolster from inside, and pull it out through the mouth. After that has been done, we replace it with what is called a balloon replacement tube. The balloon replacement tube is just so easy to put in because the track between the skin and the stomach has already formed. It has healed. It's become a very firm track. All you have to do is lubricate the tube and just push it through the hole. You need to check, of course, that you are sufficiently inside. It means except in a very fat patient, it should be in by about 6 centimeters. It should move freely when you rotate it. Then you inflate the balloon with water, not with saline, with water, distilled water, and pull it back until it doesn't come out anymore, which means it is impacting on the stomach wall. That's it. And then you fix the outside as this tube has been fixed in your husband's case. And that's all that is required. Now, you asked whether the endoscopic removal could be done at home. Theoretically, yes. In the older days, when the endoscopes were not video endoscopes, many gastroenterologists used to carry their endoscope and the small processor in their cars and go around to various nursing homes and do endoscopies there where they didn't have endoscopes. Nowadays, all the endoscopes are video endoscopes, and they require a little more paraphernalia. So it is not easy to transport that. I'm sure there will be some gastroenterologists who would be doing it perhaps. Maybe I could find out, but theoretically, yes, it can be transported and done at home.
Thank you, sir. Thank you.
Thank you, sir.
Sir, I have a question. My experience dealing with this peg tube for our mother. So for first 2.5 years, we could continue with the same one, the first one with the disc shape which was inside. 2.5 years after, it was kind of breaking from the bottom. So then we called a person from, which was very difficult at that time to call somebody at home because no endo gastroenterologists were coming that you can't do at home. So we called a person, technician kind of. So he was very good because he was handling with the gastro doctor only. So he cut this tube because it was already broken halfway. So he cut this, means use the first option which you said, and
Yeah.
and we took a chance that it should go on pass through.
Pass.
So we kept on checking the stool every day. So it took
Yeah.
around 12 to 15 days. I remember that 15th day we were so happy that this piece was up. So
That pass the matter. Yeah, I told you, most of the times you can do that, and it causes no problem at all. It passes in stool, may take a week, may take 10 days,
but yes,
but it usually passes without giving any problems.
but
Yes,
my
that's
question is because you're an expert in this area. So what is why don't we can place that kind of tube where the first replacement also would be that kind of balloon type? Isn't that possible? Something, some innovation, some kind of procedure which doesn't require endoscopic, and in the first instance only we have placed in BRT. We just do
yes.
it outside rather than going through endoscopic mode. From the stomach itself, we have some visual available, and we can insert the balloon replacement tube only at the first instance.
A balloon replacement tube is you must be using a balloon replacement tube now.
Later
I
on,
suppose.
later on.
Yeah. So you have seen the construction of the balloon replacement tube, and you know how the original endoscopic technique is to put in the tube. The original endoscopic technique is to put in, after giving local anesthesia, to put in a needle from the uh, abdomen, anterior wall of the abdomen, to pass a wire through it. And this wire is caught by a snare which has been passed through the endoscope, pulled out through the mouth, and the tube is tied to the wire, and which is pulled back in reverse direction. Now that just cannot be done with the balloon tube. The balloon tube has two channels. It has one channel for feeding and one channel for the balloon. So that just cannot be used to come through a small hole in the abdomen. So we need something that will pull the stomach wall up to the abdominal wall. The problem is, if this is the abdominal wall and this is the stomach, and you have a tube running across like this, then substances will leak from the stomach into the abdominal cavity and cause great disturbance. So you have to bring these two together. The stomach wall gets attached to the abdominal wall muscle, and then it fuses in time. In 6 or 7 days time, it will fuse to this. After that, it doesn't matter what you do with the tube. It will not separate, it will not spill any fluid. But for the first 6 or 7 days, it must be in apposition. So that is why this PEG tube is constructed in a way that it can be of a small size, can be pulled through the mouth, and come out through the abdominal wall, and then pulled tight enough to bring these two layers together so that they fuse.
Okay, thank
So,
you.
so far there is no available tube, as far as I know, that can be put in endoscopically and be removed like a balloon tube, so simply like a balloon tube.
So what
But like you already experienced, it can be done even without the endoscope.
So what about the Mickey tube? That's another type of tube in Western countries. Most of the people use Mickey.
What
Mickey is a tube. Mickey. That is
you mean a low profile tube, one which is very short?
very short, and you
Yeah.
just insert.
Yeah, it doesn't have a tube which is projecting out. It's just a stopper kind of thing. Yes, sure, it can be used. It's not very frequently used here, but it can be used. It is available, I think, though we don't use it very often. People don't ask for it. They're quite happy with this tube. It's much more expensive than the regular feeding tube. It's called the low profile gastrostomy tube. But yes, it can be used, certainly.
So in that case, we don't require to do this first kind of replacement procedure, because that's just a pocket that would be placed once and can be used for as many long years as
True,
possible.
but that is not usually that is not placed at the first go.
Okay.
In the first go, a normal tube is placed, and then at the replacement time, this tube is placed.
Okay. Okay. Thank you, sir. Thank you so much. So we have a question from Swaroop. You want to ask yourself?
Yeah, is there a way to stall tracheostomy and peg tube either by better diet control or any other non-invasive procedure?
Uh, First of all, let's be very clear that a PEG tube is only required if the patient cannot maintain his nutrition by the normal swallowing process. So you have to deliver the nutritional needs to the patient's digestive system. The best way that can happen is through the mouth with the patient swallowing. So it is only in a situation where the patient is unable to get that nutrition through the swallowing mechanism that you think of even putting in a PEG tube. You certainly wouldn't think of putting in a PEG tube in a patient who can otherwise swallow normally. Does that answer your question? I'm not sure whether that was what you were asking or. You
Yeah,
said any other way to maintain the nutrition? The
right.
ways to maintain, if a patient cannot swallow, then you have to deliver that nutrition to the digestive system either by a tube through the nose, which is called the nasogastric tube, or through this stomach, which is a PEG tube, or through the jejunum, which is a jejunostomy tube. These are the three methods by which you deliver liquid and semi-liquid nutritional products to a patient who cannot eat normally.
Okay, thank you, Doc.
Is there anything else? Are you a patient or a caregiver?
No,
I
patient.
am a patient.
You're a patient and you're able to swallow.
Yeah,
And it really, as far as we are concerned, we don't take the decision whether to do a gastrostomy or not. That decision is taken by your neurologist. He's the one who decides whether your handicap is so much as to need a PEG tube or not. Once he feels that you see, you're having ALS, but there are patients who have temporary swallowing disorders, which recover given a time period of 1, 2 months or 3 months. They are expected to recover their swallowing. In such patients, it may be better not to do a PEG tube, but just to feed with a Rice tube for a month or two until the patient's normal swallowing recovers. So, but if you have a disease or a problem which is going to increase with time, and even then you would wait until it has increased to a state where your nutrition is suffering because you can't eat.
okay. Is there any non-invasive procedures that alternate to a PEG tube?
Uh, the only procedures are a Rice tube, which goes through the nose, which has its own problems, which is why for long-term feeding, some other method is practiced. Now, the PEG tube can be inserted either endoscopically or it can be done radiologically from the outside, but it involves the cutting process and putting in a tube. Yes.
Okay. Thank you, doctor.
You're welcome.
Thank you, sir. So we have a question from Saurabh as well. Saurabh, you like to say? Let me just unmute you.
Hello. Hi. Hi, doctor.
Hi.
Am I audible? Okay. Hi.
Yes, perfectly.
First of all, thank you for your time. So this question is basically for my father. He is a patient of ALS. So it's just a follow-up question what the earlier people they had asked. So he's 71. Is age a factor if we are planning to get a PEG tube done? Age. He's 71. Does age play a role?
No.
He's not.
Age is not a factor. In fact, many of these patients are old patients, not ALS ones, but people who have stroke and who are in a vegetative state. They are very old patients. Age is not a factor. There are some factors which would contraindicate putting in a gastrostomy tube. The biggest one is that the patient should not have some bleeding disorder. So if he has a bleeding disorder, either a disease which is causing bleeding, or an acquired thing, or sometimes patients are taking blood thinning agents. In the last case, of course, you can just stop the thinning agents for a week before the procedure. But one of the major contraindications to putting in a gastrostomy tube is a bleeding disorder. Then, like I have already mentioned, a patient with cirrhosis of the liver, a patient who has a lot of fluid in the abdomen from whatever disease, whether it is cirrhosis or anything else, a patient who has a blocked food pipe, because you can't get your endoscope in, so you have to think of some other means of putting in the tube.
Okay.
A patient with serious heart disease, which makes it impossible for him to stand a normal endoscopy also. So such patients we don't put in a PEG tube, but age per se is not a factor. 71 is absolutely okay for putting in a PEG tube.
So currently he is able to eat solid food and semi-solid food aram se. He's able to swallow. So I think we can wait for the PEG tube.
Definitely, he doesn't need a PEG tube. The PEG tube will not improve his eating solids. Certainly, he can't take solids through a PEG tube. So he's absolutely fine for the time being.
Definitely.
And
Because
unless it progresses, don't even think of getting a PEG tube.
And so one more thing. So I got so in our support group. So there were people that after getting a PEG tube, does it hampers it also gets a piles problem? You get piles problem after getting a PEG tube. I mean, is that a major scenario? It depends
No,
on case.
you don't get piles because of the PEG tube. But of course, when you're using PEG tube feeding, you must ensure that your patient is getting enough liquid and enough fiber. Otherwise, constipation is a possible complication of tube feeding, and constipation can worsen a problem of piles. It won't create piles, but it can worsen a problem of piles which is pre-existing, and it may cause other issues also. So constipation needs to be avoided by using a lot of fluid and fiber in the feed.
Okay. Thank you, doctor. Thank you so much.
You're welcome. So,
Anyone else wants to ask a question? Can raise the hand in the tool. I can see. Or unmute yourself.
Can I ask Satvinder one more regarding constipation?
Sure, sure.
of course you can.
Sir, actually same constipation problem we are facing here. So we are giving cremafin. Normally we used to give cremafin normal liquid, 20 ml, but it doesn't work a lot. So we use half tablet of cremafin 10 mg. So every alternate day. Is it okay, sir? Or cremafin plus we can use?
But really, are you using enough fiber and enough fluid? If
Sir,
you don't use enough fiber and fluid,
sir,
you
we
will
are
get
using
constipation.
all vegetables. So we are using juice, everything we are giving. Still some pressure when he is passing stool or passing motion. That time he put lots of pressure. So that pulse rate sometimes increases. So we thought if you give alternate
So
day crema.
please remember that the juices have hardly any fiber. Okay, the juices have the liquid; they don't have the fiber. That's because you mentioned that you're giving him juices, thinking that you're giving him a lot of fiber with the juices.
So one time juice.
You have already discarded the fiber before making the juice. So, so the fiber is in the covering, in the chilka. So if you're using the fruit, you can use a blenderized fruit. If you're going to want to give an apple, for example, you give a blenderized apple with the chilka. Don't take off the chilka. Make it a smooth blenderized thing. Then you will get the fiber from the fruit. If you take the juice out, you're discarding the fiber in the rest of it. Similarly, you can use some green vegetables also, very thin puree to increase the fiber. You can also use fiber in the form of ready-made powders that also you can use, such as lactifiber. If you want to use a chemical solution, then you could try, you probably have tried, lactulose. Lactulose in the form of loose syrup or lactihep or something like that. That has a very variable dose range. You can start from 5 ml twice a day. You can go up to 20 ml 3 or 4 times a day. And you just have to find the best fit somewhere. Also, you could use a tablet of prucalopride. That's spelled Prucalopride. And it comes in the trade names of Pruease and Pruvict. At his age, you could give him 2 milligrams once a day.
Okay, sir. Prucalopride. 2
Prucalopride.
milligram.
Yeah. That should improve the intestinal motility, and he may not have to push as hard as he's pushing.
Okay, right, sir. Sir, we are giving puree form of vegetable puree. खिचड़ी सब सब्जी डाल के वही देते हैं, sir. Puree blend rice.
Yes, you have to puree it, but don't take off the chilka of those things which can be eaten with the chilka.
So one time juice we are giving, other 3 times that puree, vegetable puree, and other, and so like that.
That should be fine with enough liquid, and especially enough free water also. Not just liquid in the form of juices and soups, but some free water also. And if you're flushing the tube adequately, that also will get the water. Tell me something, Mrs. Anjali. When are you dressing the tube or you are not dressing?
Hello.
Yes, sir.
Yes.
Hello.
You are dressing. Actually, we don't advise dressing for these tubes. We advise that you clean them daily. But what happens, what I have seen frequently with patients who come out, sometimes the tube comes out accidentally. And the patient calls you saying what to do. Now the tube has come out. And in fact, that is possibly the most common complication we have observed with the tube is an early extrusion of the tube. But it can occur later also. What happens is the patients clean the tube and they stuff underneath the outside the bolster which fixes the tube. They stuff gauze dressings under the tube. If this is where the tube is entering, under the tube they will fix gauze pieces where it is coming from the skin. Now what that does is it gradually pushes the tube out slowly and slowly over a period of time, and the tube, if it falls out, it is still better. Sometimes it gets stuck in the muscle, and the stomach side, the mucosa hole heals, and the tube is lying within the muscle. That causes a much more, more serious problem than the tube coming out. If the tube does come out accidentally, please go immediately and have it replaced. If it comes out accidentally, you don't need an endoscope to remove it. All you have to do is put a balloon replacement tube inside. But that must be done immediately. If you wait for 48 hours, even sometimes 24 hours, the hole may close.
Hi, Doctor.
Every alternate day we are doing dressing, not daily.
You don't really need to dress it. You need to clean it.
Yes, sir, clean it.
And any patient who is mobile can actually have a bath with the tube and no problem.
Okay, sir. Thank you.
Thank you, sir.
Thank you. Thank you, sir.
So, Tanisha, you want to ask something? So, please go ahead.
Yes, I actually wanted to ask, Doctor, so my father has ALS and it is early stages still, and like swallowing and all is not much of a problem, but the phlegm has really started increasing. Is this something that is related to gastro issues? Phlegm.
I didn't catch that question. What has started increasing?
The phlegm.
Phlegm has started increasing. Okay,
increasing now.
Sorry, go ahead. Say what you want to.
Yeah, so I'm saying that my father has ALS. It's early stages. Swallowing and all is not an issue. But phlegm has really started to increase. We have been taking some medicines for it and some cough syrup that doctors have recommended, but it's not really helping. Is there...
Okay, you need to consult your doctor and find out. Sometimes it can be related to swallowing issues because or reflux. Sometimes the acid can reflux from the stomach, enter the trachea and cause a phlegm issue or even an asthma issue sometimes. So you need to consult your neurologist and see if he thinks that reflux may be a problem causing his phlegm.
Okay.
If it is, then he can probably try some medicines initially to prevent that reflux or cause less damage from the reflux. If that doesn't work, then sometimes, even though the patient is swallowing, sometimes a peg tube is suggested as a measure to control reflux. But I must say that not all the scientific data available shows that reflux is always prevented by doing a peg tube. The primary function of doing a peg tube is for nutrition, providing nutrition. It may help in preventing reflux also, but otherwise your patient's phlegm would in no other way be related to his feeding issues unless he's either while swallowing he's aspirating some of it into the trachea, or after swallowing he's refluxing some of it back into the trachea.
All right. Thank you so much, doctor.
Yeah.
Thank you, sir. So, anyone else wants to ask the last question? We already taken a lot of your time, sir.
Oh, no problem. It's Sunday, I am free. Absolutely.
But we are making you busy. We are keeping you busy.
That is good.
So Rajiv also wants to ask something. Rajiv?
Sure.
Yes, yes, sir. Last question, like already discussed game. So like if now certainly that essay will be on RAS too. So you were saying something that there is some issue with the RAS too when it is used for a longer time. So what is
Sorry,
that something which should be?
I'm sorry I didn't get your audio too clearly. What was your question?
The question is that with a RAS tube for the longer duration, you said that some
Yes.
complications are there. So what are
Yes.
those or what we should be careful of that thing?
Yes. The most feared one is that the pressure of the Ryle's tube causes erosion of the nasal cartilages. And secondly, the Ryle's tube is also believed to be sometimes contributing to reflux. That is, again, acid coming back up because it is keeping the lower end of the food pipe open. It may be contributing to reflux. And these are the two main reasons why for long-term feeding, a gastrostomy is preferred. Also, the tubes that are used for nasogastric use are generally much thinner tubes than the gastrostomy tubes, and so they can only take a limited thickness of the food that you're preparing. So in the Western countries, now even in ours also, now that you have these formula feeds available, which can be practically liquid, you could use full nutrition through the Ryle's tube also, even through a thin Ryle's tube or a thin nasopharyngeal tube. But the gastrostomy tube is more comfortable. It allows you to give a wide variety of feeds, and it is not associated with these complications of reflux and of nasal cartilage ulcers.
Okay. Yeah. Okay. Okay.
But temporarily, certainly, the Ryle's tube, if it's for a temporary use, a Ryle's tube is good enough.
But as I already said that she is suffering from GAVE that and
Yeah.
APC was done. So
Yeah.
So that's what is something going around my mind. Like now.
Tell me the person you mentioned that his GAVE was detected and treated at Gangaram Hospital, correct?
Yeah.
Yeah.
Sharma, Dr. Pradeep Misra.
So what did they advise? Because they've seen the rest of the stomach as well, not just the antrum. And I think they would be aware whether she has portal hypertension or not. What do they think as far as putting in a peg is concerned?
Like at that time, there was no swallowing problem, and so we did not discuss at all.
Okay.
It was 2018, and then
Okay.
after that, because of GF, she always had the anemia issue. Okay, so like we used to give Gilajo injection. Now, but it is quite good. Means the maintenance of the blood HB is good, but I don't know
Yeah,
how
after
severe it
the
has gone.
yeah, after the APC, that would have improved because the gastric bleeding would have stopped.
Yes. But obviously, I'm not discussed to them about the peg. To be very frank, like we did not have that. At that time, it was okay. Just it is 3 months ago that swallowing deteriorated, and we have to go on RAS tube because of the COVID and can't go out right now for peg. So that's what the thing. So for the first time, I'm discussing directly with you only about the peg with gave issue.
Yeah, so it really depends on what is the underlying disease with the GAVE, because GAVE, is antral vascular ectasia. Now, if it is only confined to the antrum and does not extend into the body of the stomach, and it is not associated with liver cirrhosis, then it might be considered. If it is associated with liver cirrhosis, that would be very risky.
Okay, sir, no problem. After COVID, we'll try to get in touch with you directly, and we will see what can be done, if it can be done or not. That's what after COVID we can just catch with you then, sir.
Sure, you're welcome.
Okay, thank you, sir.
So anyone else wants to ask? Otherwise,
yeah, I have.
Okay, hi Kumuda.
Yeah, hi. Hi, doctor.
Hi.
Yeah, this is Kumuda. My dad is a patient. So my dad is on peg from past 2 years. So the weight is only on the left side of the stomach.
The what? Sorry?
Weight is on the left side of the stomach. I mean, it's bloating only to the left. Right? Not much. The stomach is only to the left. I mean, the weight is more on the left side of the stomach.
I'm not sure I understand what you mean by the weight. What weight?
I mean, it's bloated to the left side. No, right side is...
it is bloated. You mean
yes.
The stomach is...
Yeah, the weight is on the left side actually.
He had an endoscopic gastrostomy, not an open operative.
Yeah, no, endoscopy. The endoscopy, along with the tracheostomy and the endoscopy, together that happened actually 2 years back.
Okay, so...
we have not changed the tube yet.
No, you think the left side of his abdomen, his stomach, is bulging out more than on the
right side. Exactly, yeah.
You mean, and this has happened recently, or it has been there from the beginning?
No, not from the beginning.
Well,
we noticed recently. Yeah.
Most of the stomach lies on the left side actually. So if you're, what size feeds are you using?
200 ml, doctor.
200 ml shouldn't be a problem at all.
Okay.
You can just turn him a little bit to the with the right side down and the left side up.
Okay.
And, that should maybe free up. He's not vomiting or anything, is he?
No, doctor. No such.
If he's not vomiting, then the passage is quite patent, and the tube is at the same position. Tube is at the same position from the skin.
Okay.
So if that is so, I wouldn't worry about a little bulge on the left side. Most of the stomach is on the left side.
Okay.
If you can send me a picture, then maybe I could.
Sure.
Better opinion.
Yeah, I'll do that. And can you suggest any good tube feed for the diabetics, doctor? Diabetic patient? Tube feed.
Are you not in touch with a nutrition dietitian?
Yeah, but she's given the diabetes. She's given one, but we are not so happy with that. Can you suggest any other?
Are you also not using natural food purine?
Yeah, that we are using, doctor. That we are using.
Well, I'm not the best person to talk about this because I'm neither a specialist on nutrition nor on diabetes.
Okay. Fine.
Ensure ensure DM is something we sometimes use in diabetic patients, but
Okay.
perhaps this would be better answered by a dietitian or by a
We are
diabetologist.
using Frisbin DM now.
Frisbin
Yeah.
is okay. Yeah, that's okay.
Fine, doctor. Thank you.
So
Thank
there's a question from Usha from Andhra Pradesh. She's saying the audio is not clear, so she's not asking. So I'm asking on her behalf. His father, her father is facing problem of having multiple motions, and while they do that, there's a lot of gas which is coming out. So something we can do is she's giving that, I think, Pan 40, the gas tablet. What?
So, is that all, or is there some other part to the question?
No. I think she wants to say only
That
this.
is it. So the point is, A, whether these motions, number of motions are normal formed motions or they are loose watery motions. If they are loose watery motions, then they probably need to consult somebody and take some medication for it. Number of motions increasing is possible if you are feeding too concentrated feeds, if your feeds are too concentrated, or if they are too cold. Temperatures must be also maintained at regular room temperature or body temperature. Too fast, if you're feeding too fast, then also you can develop loose motions, frequent motions, and also loose motions sometimes. So if they are not loose watery motions, then she does not need any intestinal. Of course, the hygiene of the products that you're using for making the feed, for storing the feed, and for giving the feed is also important. It's like a baby's bottle that you would boil and keep sterile and things like that. And also the feed, if you're preparing in one go, then you have to keep the remainder of the feed in the fridge. But these are all common things which everybody knows. If despite using all that, you are getting a problem of loose motions, then you may need to be treated, he may need to be treated for an intestinal infection. If it is not loose motions, but just frequent motions, then again, increasing the roughage, keeping the concentration of the feeds a little lower, especially if you're using these formula feeds, then if you use too concentrated a solution, it can cause looser motions. Medication wise, like I said, if it is loose, really loose and watery, then probably after consulting your primary physician, you could try rifaximin 400 milligrams 3 times a day for 7 days. Or if it is not watery, then you could use, if it is really troublesome, you could use Imodium 1 or 2 tablets a day, but really consult your physician who knows the patient so much better than I do.
Okay, thank you, sir. I think that was, she was concerned. She mentioned me that his father was having normal motions, but yes, the gas problem is the main concern. Why the gas?
What tablet did you say she was using? Pantocid?
Pantocid for, I'm assuming she has not mentioned any tablet, but she said
Okay.
gas tablet.
If she's using a derivative of Pantocid called Pantocid L, that also can cause frequent motions. So if she's using Pantocid L, then she should stop the Pantocid L and take plain Pantocid. If gas formation is a big problem, then she can also add Medigas tablets, which just absorb the gas, essentially work like charcoal, 3 times a day.
Okay, thank you, sir. Thank you.
Yeah.
Sir, there's a question from Pinakin. He's a patient himself. So he's saying, with regard to eating and consuming food which doesn't lead to gas problem, what precaution one should take? He doesn't have a peg as of now. He is able to swallow.
He doesn't have a peg, but he's facing gas problems, and he's asking what food should he avoid.
Yes.
Well, he should avoid very highly spiced foods. He should avoid all dals with chilka, chilke wale dal. So in a sense, he's going to have dhuli hui dals. But urad dal, whether it is dhuli hui or with chilka, all of them, both of them cause a lot of gas production. Then he should avoid certain vegetables like cauliflower, broccoli, mooli. These are vegetables that he needs to avoid. Reduce the quantity of spinach also. These are the things he needs to avoid.
Okay, thank you, sir. So, sir,
Yeah.
is this when person is on PEG? We have faced the problem with our mother also earlier when she was there. So, we used to open the PEG because sometimes it was too much. If we open the PEG tube, the gas comes out along with a little of water which was lying inside that PEG tube, because we should keep the water always filled in the PEG tube. So is this a right way to go ahead? Means if we
See,
say,
the normal stomach will contain certain amount of gas.
but if it is
And
more than average, means it's not normal, and for a particular day the gas is, you see a bloated stomach and you try to open the peg and a lot of gas comes out. So is this okay to do that?
if it is just happening occasionally, that is okay. And is the patient also on a tracheostomy or not on a tracheostomy?
Uh,
Also on a tracheostomy. Sometimes patients, you see, most of the gas in the stomach, not lower down, most of the gas in the stomach comes from swallowed air. Patient is swallowing air, whether he is aware of it or not. Most of the air is coming from swallowed air in the stomach part. So if it happens once in a while, or even more frequently than once in a while, it's not important as long as the patient is not getting distressed from it and he's not vomiting.
okay.
Why did you need to open the tube?
Because
Normally the tube is kept closed when you're not feeding.
yes, but sometimes we could see the stomach is bloated
Yeah,
above
okay,
our
that's
normal.
okay.
So it
And
happened number of times in our journey.
We used to open
She's no more right now. She 2 years back she passed away. But
okay.
yes, 8-9 years she was on PEG, so we managed.
Yeah, so if there is a lot of bloating in the upper part of the abdomen and you let the gas out, it will solve the problem. If there is bloating all over the abdomen, if the whole abdomen is swollen up and the patient is not passing any stool or wind and is possibly vomiting also, then you need to be concerned and see your doctor.
Okay. Thank you. I think we don't have. I think you completed all the questions. More than what I was expecting. We asked for 4. But
No,
yes.
you told me yesterday evening, so I didn't know what your format was going to be, whether you wanted me to make a presentation or not make a presentation. I didn't have access to my office material Saturday evening and Sunday.
No, this
So,
worked best. If this is a
so as an informal thing, it's fine, absolutely fine. I enjoyed it.
Thank you so much, sir, for thanking.
But I must say that you, many of you have been caregivers for these patients for years and years.
No, you can't.
And you know the problems and their solutions probably better than I can offer.
No, sir. I was very much confused about the Mickey. You explained the group so well. So it was wonderful.
No, for you, this is a daily thing. You're doing this day in and day out. For me, it's a one-off. I see the patient wants to put in a tube, maybe wants to change the tube, but you're the people who are giving the care.
No. So you have been wonderful in sharing your knowledge and all the expertise and the tips with the group. So thank you so much from all of us here. Thank you.
Thank you.
Thank you, sir. Thank you, sir.